Our first speaker today is Ela Harris. Ela did both her BS and her PharmD from the University of Philadelphia College of Pharmacy. She did specialty residencies after that in South Carolina. She's now an associate professor in both the School of Medicine and the School of Pharmacy in the University of Minnesota. Prior to that, she was a faculty member at the College of Pharmacy in St. Louis. She specializes in ambulatory care. She's a past AmCare PRN chair. She's a past fellow of ACCP. And today she's going to come to talk to us on ambulatory care. She specializes in your practice in asthma, anticoagulation, smoking cessation, diabetes. She is a jack of all trades and a master of all. So it's all yours, Dr. Harris.
Thank you, Brian. Okay, great. And you've got the Minnesota accent pretty good. That was pretty close. I'm not from there originally, so I don't have a Minnesota accent. So good morning, everyone. The topic this morning is ambulatory care, and obviously ambulatory care covers a lot of things, and I was assigned 4 topics within ambulatory care. So today we are going to talk about asthma, COPD, anticoagulation, and adult immunization. So just a small fraction of really what ambulatory care is. And I have a lot of information to cover, so buckle your seatbelts. Keep your hands and arms inside the ride at all times. And hopefully you had some coffee this morning. So starting with asthma. When a patient with asthma is being seen or being assessed, the first step is assessing their asthma severity. And this is a complicated table. Now all the information from asthma is going to come from the asthma guidelines from the NHLBI, which were last updated in 2007. And we all know that we're waiting for a lot of new guidelines from the NHLBI. So asthma, I don't think, is their priority right at this minute, but I would assume that soon there will be an update in the asthma guidelines. So for classifying asthma severity, it is based on impairment and risk. So the impairment looks at symptoms, night awakenings, beta agonist use to treat symptoms, and interference with activity, and then lung function based on spirometry. And we see here the rule of 2s, where to move up from intermittent asthma into persistent asthma, it's easy to remember the 2. So the symptoms would need to be 2 or fewer days a week to stay in intermittent, a night awakenings 2 or fewer times a month, beta agonist use to treat symptoms if someone is using a beta agonist, and oftentimes people come in for their initial assessment and they're using their family member's albuterol. That's a very common scenario. 2 or fewer days a week, no interference with activity, and lung function normal on spirometry. And that would be intermittent asthma. And anything beyond that, even if only one category falls into persistent asthma, the patient would be diagnosed with persistent asthma and would need to be on a controller medication. Now, if someone falls into some different categories, so if their symptoms overall are here, but their nocturnal symptoms are under the moderate persistent category, and their beta agonist use is over here, so they're all different categories, you would go with the category with the highest severity. So if someone has one piece of the puzzle in moderate persistent, that would be their categorization. And I want to point out that even with mild persistent asthma, the lung function, the FEV1 on spirometry, can be totally normal. And that throws people off sometimes, where someone comes in and they're having some wheezing, shortness of breath, and spirometry is done, and the doc says, well, their spirometry is normal, so this probably isn't asthma. Well, yeah, it probably is asthma, but it's just that they only have mild persistent asthma. Now, you take into consideration the risk as well, and that's the use of systemic steroids. And that could be oral steroid burst, or it could be IV steroids, it could be hospitalization, it could be urgent care, it could be treated in the office. But any burst of oral corticosteroids, if it is 2 or more times a year, they're automatically in persistent asthma. And if someone has something that falls under 2 or more times a year and they have persistent asthma, but everything else falls under intermittent, those people who never have symptoms except for twice a year when they have a URI and then they have an asthma exacerbation, then they still would be considered to have persistent asthma. And also on this busy chart here, you see that once a patient is classified in their asthma severity, the treatment step is determined. And the treatment step is based on their asthma severity, and it's not go low, start low and go slow. It is you start at the treatment step where the patient's severity is at. So our first case, we have a 20-year-old woman presenting with coughing and having trouble breathing twice weekly for 1 year. Activity is not limited. No nighttime symptoms. FEV1 is 85% predicted. She's on no meds. What would best classify her asthma? You would use your cards. I'm seeing lots of blues. So she's having symptoms twice weekly. So when we look back at our chart, we see that 2 or fewer days a week for symptoms would be classified as intermittent. So she has intermittent asthma. Now on the chart, if you recall, the treatment steps are listed as step 1, 2, 3, 4, 5. And this is the treatment. These are the treatment steps, and these are for adults, 12 years of age and older, as well as the assessment that we talked about. There's different criteria and different treatments for 2 different pediatric age groups as well. Right now we're just talking about the adults. So step 1 is intermittent asthma, and then it moves up from there. And below the line here are alternative therapies, and above the line are preferred. And you might be looking at this. Oh, I wanted to point out first, it's right here, that cromolyn and nodocromil metered-dose inhalers were available when these guidelines were written in 2007. They're no longer available, but I just kept them on the algorithm because that is what the guidelines say. So then you're looking at this and you say, well, low-dose inhaled corticosteroids, do I just kind of estimate what a low dose would be, or are there certain criteria? Well, there are criteria. And it depends on the inhaled corticosteroid, and there are specific criteria for what is low dose, what is medium dose, and what is high dose. And you can see that they're not equal potency, so depending on the inhaled steroid, the dose is going to be different. So if you're switching from one to another, it's not going to be a microgram to microgram switch. It's going to be dependent on the potency of the inhaled corticosteroid. So our patient from case 1 with intermittent asthma, which medication is the best option for that patient? Sorry, my little squares are off. Okay, so I see a lot of blues. So we have intermittent asthma, step 1, going to our chart. Step 1, short-acting beta agonist, PRN, she would not need a controller therapy. So we talked about diagnosing the patient, categorizing them into their asthma severity, and starting treatment. And so after that is done, any of the follow-ups is assessment of their control. So we're not going to start over when they come in and they have more symptoms or fewer symptoms. We don't recategorize them every time. What we do is we assess their control and then take an action based on their control. So the control, as you can see, this is similar to the assessment with intermittent versus persistent asthma, and well-controlled, the criteria are very similar to intermittent asthma. So that would be considered, if the patient comes in and meets that criteria, they would be well-controlled, no action is necessary, and actually someone is stable for 3 or more months, you can step down therapy, and that's sometimes a step we forget. Like 5 years later, they're still on the same dose of inhaled steroid we started, but they haven't had symptoms in a very long time. We always need to remember you can step down the therapy. If someone is not well-controlled, they would meet this criteria. And I wanted to point out an additional step here, and this is the ACT, the Asthma Control Test questionnaire, and there is one for adults and one for children, and we use this very commonly in practice. Every patient that comes in our clinic for asthma has to take an asthma control test at every visit they come in, even if they're not coming in for asthma, because they never seem to come in for their follow-up asthma appointments. And so these numbers are based on their control. And depending on what their number is for their asthma control test, we can assess their control. And you can see if they're not well controlled, the action is to step up 1 step. And if they're very poorly controlled, then you could consider a short course of oral corticosteroids and step up 1 step and possibly even 2 steps if their asthma is very, very poorly controlled. So now our patient has started coughing at night about once a week, and this has been going on for several months, and so it's not an acute exacerbation. What would be the most appropriate treatment for her? So it's a two-step process. We're assessing her control and then determining her treatment. Okay, I'm seeing a lot of yellow Ds. So let's walk through it. She is having nighttime awakenings now 1 to 3 times a week. So she falls under the not well-controlled category. The plan would be to step up 1 step. And she right now is on a short-acting beta agonist PRN step 1, and we're stepping up to step 2, which is low-dose inhaled corticosteroids. And when we look at the choices, we need to pick the one that is in the low-dose category, which would be the fluticasone. And I just wanted to point out here, salmeterol, for asthma, long-acting beta agonists should never, ever, ever be used as monotherapy. For COPD, they can be, but asthma, they should never be used as monotherapy. There's a possible increased risk of death from monotherapy with long-acting beta agonists. So now our patient returns 1 month later. She's no longer awakening at night. She uses her albuterol once a week to treat her symptoms. But now she started working out at the gym. She hasn't really worked out before, and she's just trying to lose some weight and started working out. And she's noticed she's had some symptoms when she's working out. So she uses her albuterol, 2 puffs, 5 days a week before she goes to work out. But then while she's working out, she's okay and she doesn't have any symptoms. What is the most appropriate action? Okay, seeing a lot of blues. The point of that case is to mention that her nighttime awakenings are still 2 or fewer times a month. She's well controlled, and her short-acting beta agonist use for symptoms is 2 or fewer days a week. And when someone uses albuterol for exercise-induced asthma and they use it before exercise, we don't count those puffs. We don't count those as days per week of beta agonist use. Unless they actually have symptoms while they're exercising and then they need to use it, then we would count those puffs. We do not count the preventative puffs. So she's going to continue her therapy. So now we're going to move on to a child, a 9-year-old boy. He has asthma symptoms 1 to 2 times a week. He's awakened twice weekly at night with coughing and trouble breathing, which best classifies his asthma severity. Now, because I didn't show you the chart yet, I'll just kind of work this one. We'll work through this together. For children aged 5 to 11, the chart, when we're assessing someone's asthma at baseline and we're trying to determine if they have intermittent or what severity of persistent asthma they have, the criteria is the same except for the lung function. Those are the only things that are different, and the other difference here in red is that even if someone has severe persistent, we start at step 3 or 4. We don't start at step 4 or 5. So our patient falls into 2 different categories. For daytime symptoms, falls into the intermittent category, but for night awakenings, falls into the moderate persistent category. So again, when someone has 2 different categories, we go with the more severe, which is moderate persistent. So this boy has moderate persistent asthma. So in addition to albuterol as needed, which is the best for his initial therapy? So we can work through this one together as well. We already know that he has moderate persistent asthma, and so we're going to start at step 3. So this is a little different because this is for 5 to 11 years of age. And in your chapter, it's the chart for the treatment, the stepwise therapy, looks a little bit different. I don't have it looking like this. It's more of in a table format, and all the ages are combined into the one table, so it's easier to see what the differences are between the age groups. But for him, we're going to start at step 3, which is low-dose inhaled corticosteroids plus a long-acting beta agonist, leukotriene modifier, or theophylline. Yes, theophylline is still listed there as a first-line option, but it really is, should not be used as a first-line option. Or medium-dose inhaled corticosteroids. Now, I bolded the medium-dose inhaled corticosteroids because per the guidelines, in a child of this age, for initial therapy, the medium-dose inhaled corticosteroids is the preferred option, not the combined with the long-acting beta agonist. However, if this child was stepping up from step 2 to step 3, then the combination with long-acting beta agonist would be okay, just not for initial therapy. So these are the doses for age 5 to 11 of the inhaled corticosteroids, and these are very different. So the low dose, medium dose, high dose are much lower for this age group, and then when we have the 0 to 4 age group, the doses are even lower. And I've also added budesonide for nebulizer use because in children this is an option, whereas adults we don't really use a nebulizer all that often. So for medium dose inhaled steroids, the fluticasone choice falls under the medium dose. So he would start with fluticasone 110, 1 puff BID. And for age 0 to 4 is included in your chapter. Again, the classification, treatment, dosing, and assessment are all different, but I'm just not going to go over that due to time. So asthma action plans. This is another very important thing, and it's a big initiative in our clinic to make sure every patient has an asthma action plan, and that we redo their asthma action plan every year, and that if their children, the schools have the asthma action plan, and the parents, and they know it and they understand it, and at every visit we check if they have it, do they know where it is, do they know what to do. So it's a big initiative. It's very important that we do these asthma action plans. So for the asthma action plan, it used to be based on peak flow meter readings, where patients would always have a peak flow meter at home. They'd check it every day, several times a day. They'd keep a peak flow meter diary. And I remember doing this in practice. We did this all the time for all asthma patients. This is 15, 20 years ago. That used to be the commonplace thing we do. Now the asthma action plans, the guidelines say you can use symptom-based or peak flow-based. And the peak flow monitoring is not used as commonly, so more commonly we're just doing the symptom-based asthma action plans. And it's broken down like a stoplight to green, yellow, and red zones. And so for the green zone, that means patients doing well, no problems, no symptoms, and the plan is to take the controller drug only. And that's an important educational point because a lot of times patients will stop their controller when they feel good, because if they didn't understand that's why you feel good, because you're taking your controller, they might stop it on their own. And they can use albuterol prior to exercise if they have exercise-induced asthma. And if they have some periodic mild symptoms, they might need to use an albuterol now and then when they go over to their friend's house that has a cat and that triggers their asthma or anything like that. They might just have it once in a while where they need an extra puff. And so the asthma action plan may look like this. It's just an example. And what you'd write in here would be their controller. You'd write out whatever controller medication they're taking and what their dose is, and that they can use albuterol as needed periodically. The yellow zone means that they're getting worse, they're having some symptoms of wheezing or dyspnea, and the plan for the yellow zone would be to use their albuterol, their short-acting beta agonist, 2 to 4 puffs by metered dose inhaler or 1 nebulizer treatment, and that can be repeated in 20 minutes if needed. And when you look at the guidelines, 6 puffs also may be used, but generally that's not needed, and so for the yellow zone, it's going to be more of a 2 to 4 puff. And after 1 hour of initial treatment, the patient should be reassessed, and then moving forward from there depends on their response to therapy. So what you might fill in here in the yellow zone, you'd put their albuterol, you put 2 puffs, repeat in 20 minutes if needed, then reassess in 1 hour. And oftentimes if someone is going into the yellow zone, we can kind of keep them out of going into the red zone by doing regular albuterol for about 48 hours. So oftentimes we say use your albuterol every 4 hours for 1 to 2 days and then go back to PRN use. And contact a physician for follow-up care. Do the quick relief medication again if after 1 hour the control or the response is not adequate. And they used to say double your inhaled corticosteroid for 10 days and then go back down to your previous dose, but that was taken out of the guidelines because there's not sufficient evidence to prove that this does anything. And in the yellow zone, also oral corticosteroid burst could be considered. So after that initial treatment, 1 hour after the initial treatment, if there's a complete response, you could consider an oral steroid burst, but not necessary. For incomplete response, repeat the short-acting beta agonist and then add an oral corticosteroid burst. And then for poor response, repeat the short-acting beta agonist, add the oral corticosteroid burst, and then contact the clinician immediately. And if they're not available, then go to the ER, call 911 for severe distress. And for the dosing of the oral corticosteroid burst, it's prednisone 40 to 60 milligrams once a day for 5 to 10 days. So it's kind of a wide range. But what's sufficient, what we do very commonly in clinic, is do a 50 milligram tablet once a day for 5 days. It's easy. It comes in a 50 milligram tablet. It's 1 tablet. It's easy to remember because of the 2 5s, and it's just something that is just kind of the standard what a lot of people will use. Because a 10-day course is really not necessary for an acute asthma exacerbation. So the red zone, that is where there's marked wheezing and dyspnea. Someone might not be able to speak more than short phrases. They're using accessory muscles. They're feeling drowsy. They're just not doing well at all. And the treatment for the red zone would be short-acting beta agonist, 4 to 6 puffs by metered dose inhaler, or 1 nebulizer treatment. This should be repeated in 20 minutes, and then can repeat again in 20 minutes if there's not complete response. And in some resources, they recommend up to 8 puffs. And I know that in our practice, we often will recommend the 8-puff treatment. But in the guidelines, it does say 4 to 6 puffs. And then after that assessment, so once you treat this red zone, you do need to reassess the patient after their first treatment of albuterol, because if it's that severe, they're going to need to go to the emergency room and not just wait for that full hour once they get 3 doses in them. And then an oral corticosteroid burst should be added for sure. And if someone at the onset of this red zone exacerbation they can't talk, they can't walk, they have such severe shortness of breath, their lips or fingernails are blue or gray, they should go to the emergency room right away or call 911. But while they're waiting for the ambulance, they can still do their treatment. So for the red zone, albuterol, this might be an example of an asthma action plan, 6 puffs, repeat in 20 minutes times 3, and reassess after the first 20 minutes. And for sure do a prednisone burst. And I think that the key here is that after the first treatment, that if 15 to 20 minutes after that first treatment, complete response is not seen, they really do need to go to the emergency room. And something just to not forget, provide that prednisone prescription ahead of time when you're giving the asthma action plan, and tell the patient to fill it and have the actual prednisone tablets at home, because in the middle of the night on a weekend when the pharmacy's closed and they're having a severe asthma exacerbation, they can't go to the pharmacy to get it. They have to just go to the medicine cabinet and open it and take it. So it's important that they know that they should fill it right away and have it on hand. So we have a 25-year-old woman using fluticasone, salmeterol, 250/50, 1 puff BID, and albuterol as needed, and you're developing asthma action plan for her. Which are her green zone instructions? Here's your cards. I'm seeing lots of red. Okay, and that is correct. We just continue to control her and could use albuterol as needed. What are her yellow zone instructions? What's that? No, this is for yellow zone. Sorry. Which are her yellow zone instructions? I'm seeing not a lot of cards. Some reds. So this would be where you'd use the 2 puffs, repeat in 20 minutes if needed, and then reassess. And what about her red zone instructions? Okay, I'm seeing some greens. Yep. So we do 6 puffs, repeat in 20 minutes, start prednisone, and then reassess. And I have to say that when I teach family medicine residents, and when I tell them that the patient can use 6 puffs, oftentimes they're surprised. They say, "Really? The patient can use 6 puffs?" And then when you tell the patient that, they're like, "Really? I thought I could never use more than 2 puffs at a time." So the word really isn't out there. Don't assume patients know they can do this, and don't assume that the physicians know that they should tell the patients to do this. Okay, just real brief on talk about asthma exacerbations in the urgent or emergency department setting. So someone comes in with an exacerbation. It's classified based on their symptoms and their signs, and then also their spirometry results. And depending on the severity of the exacerbation, then the treatment is going to be different. And this is all outlined in your handout. So I have a patient, a 25-year-old male, presenting to the emergency department with shortness of breath at rest. He's having trouble with conversation. His exacerbation is so bad. He used 4 puffs of albuterol at home with no resolution of symptoms. His FEV1 is checked and is 38% predicted. So which would best classify as asthma exacerbation? Well, he is having dyspnea at rest, and it's interfering with his conversation, and his FEV1 is less than 40%, so he'd be classified as a severe exacerbation. What would be the best initial therapy for him in the emergency department in addition to oxygen? So for a severe exacerbation, we'd need to give oxygen, and then we want to give the high-dose albuterol, plus ipratropium. So in an acute situation, ipratropium is added, and then oral corticosteroids. The IV corticosteroids are reserved for life-threatening or impending respiratory arrest. So D would be the correct answer. Okay. So that was everything you wanted to know about asthma in about half an hour. And so that was a kind of a really quick review of everything. And we are now going to move on to COPD. So when we look at the treatment of COPD, the gold standard, no pun intended, are the GOLD guidelines. And these are global guidelines for the assessment and treatment of COPD. And what they say is to consider COPD and perform spirometry in anyone who's more than 40 years old that has either dyspnea, chronic cough, chronic sputum production, or a history of exposure to risk factors, and the most common risk factor will be a history of smoking. And the GOLD guidelines are updated every year or two, and the 2012 update had a huge amount of differences in the treatment than the previous guidelines. They just completely revamped everything. And then the 2013 guidelines, there are some changes in the treatment, so I am going to outline those, but just wanted you to know that there are some differences now. But if you haven't really looked at the guidelines or thought about COPD in the last few years, the treatment is very different now, and the assessment as well. So the criteria for diagnosis of COPD are symptoms and the risk factors plus the FEV1 over FVC ratio of less than 70%. So you can't diagnose COPD without spirometry. And sometimes you want to, or people want to, because, oh gosh, this first patient is 60, they've been smoking for 40 years, 2 packs a day, and they're having shortness of breath. Well, duh, of course they have COPD. Yeah, well, you can't really diagnose it unless you do a spirometry. And then the other thing there's 3 validated symptom scales. And the previous guidelines had the first 2, and then the 2013 guidelines added this third questionnaire. So we have the Modified British Medical Research Council Breathlessness Scale, the MMRC, the COPD Assessment Test, which is the CAT or CAT test, and the Clinical COPD Questionnaire, which is the CCQ. And these are slightly different in what they ask, but basically they're assessing someone's symptom and the severity of their symptoms and how bad their COPD is based on their symptoms. And before 2012, the assessment of COPD was all just based on their FEV1. You'd stage someone, stage 1, 2, 3, 4, just completely based on their FEV1, and now it's different because they've added the symptom scores. So just to outline this a little bit, in the past, my microphone is here so I can't move too far. In the past, this is all we assessed a patient by, just their FEV1, and they were considered stage 1, stage 2, stage 3, or stage 4 based on their FEV1. Well, now that they've looked at severity and risk, they've added if the patient has less symptoms or more symptoms. And they've also added risk. They've looked at exacerbations per year, and then for symptoms, they've also added the symptom scores. So you kind of can put a line here because A and B have the same spirometric classification, and C and D have the same spirometric classification. And then it's just based on what their symptoms are, if they're going to be in group A or B, or in group C or D. And their symptoms are based on the symptom score, and also their risk as their exacerbations per year. So now, instead of saying, this is someone with stage 3 COPD, we say this is patient group C, and that's how we classify them. So we add the symptom score and the risk. So it's actually a better classification system. And the therapy now, it used to be just based on their FEV1. Now it's based on patient group. So depending on what patient group they are, we have a recommended first choice. And there's some alternatives here. And the thing to realize is that there's not really great outcome data with treatment of COPD. We don't have mortality data. We have some data with decreased exacerbations and some morbidity, but the data isn't excellent. So that's why there's choices. A lot of times you can do this or this or this or this. And then once someone is already on this And either if it's contraindicated, they can't take it, they can't afford it, you'd go to the alternative choice. Or if they're already on this and they're not controlled, then you might have to step up and go to the alternative choice. These other possible treatments column, these are things that can be used in addition to their other chronic therapy. So you might add a short-acting beta agonist to their long-acting beta agonist. These can be used in conjunction. And I'd like to point out that, again, remember we can draw that imaginary line here. We have groups A and B with the same spirometric classification, and C and D with the same. And just pointing out that the inhaled corticosteroids, which are here and here, you notice they are not recommended until patient group C and D. So patient groups A and B should not use, or it's not recommended to use inhaled corticosteroids at all because the evidence just is not there. And even from 2012 to 2013, they've changed this table a little bit. They've changed the columns. They've changed some of the things in here. So there are some differences. Now, there are also COPD guidelines that haven't been updated in a few years, and these are from the American College of Physicians, American College of, not clinical pharmacy, but chest physicians, the other ACCP, American Thoracic Society, and European Respiratory Society. And you can see they're just kind of more vague, and this again comes from the fact that there's not great evidence. So they just have some general statements, and if you look through this, they pretty much mirror what the GOLD guidelines say. They just have some more general statements, and then they have what the evidence is, and if there's low evidence or medium evidence, that's where we're coming up with these recommendations. And the grade, weak, W is weak evidence or weak recommendation, and S is strong. And all that is in your chapter. Just want to point out a relatively new agent for COPD. It's actually an oral agent. It's roflumilast, and it's a phosphodiesterase 4 inhibitor. It's anti-inflammatory. There's no direct anti-bronchodilator effect. And it is indicated as chronic treatment to reduce the risk of COPD exacerbations in patients with severe COPD. So their FEV1 is less than 50% predicted, so this would only be in patient groups C and D. And only if their COPD is associated with chronic bronchitis and a history of exacerbations. And there is some evidence regarding reduction in exacerbation risk and even a reduction in severe exacerbations requiring hospitalization or causing death. And evidence is B. So they've also studied it when added to long-acting bronchodilators, but they have not looked at either adding, if someone's on a long-acting bronchodilator, adding roflumilast versus adding inhaled corticosteroids to see which one is more effective. They have not studied that, and I believe that those studies are underway. So we have a 50-year-old male smoker with COPD. Spirometry showed an FEV1 over FVC ratio of 60%. Pre-bronchodilator FEV1 70% predicted, and then post-bronchodilator FEV1 72% predicted. So you can see there's not improvement like you would see with asthma. The symptoms are very bothersome to him, and his MMRC score is grade 2, and he's had one exacerbation in the past year. So what would be the most appropriate GOLD classification for this patient? Okay, I'm seeing mostly red, B. So this patient falls under the FEV1 between 50 and 80% predicted, and he's had one or less exacerbations per year. MMRC is 2 or greater, so he would indeed be patient group B. So which pharmacotherapy option is the most appropriate for him to initiate in addition to PRN albuterol? We shouldn't have to look into this too much because remember he's patient group B, and when are inhaled corticosteroids added? That's C or D, right? So we know that C and D are incorrect. So I think I see a lot of the right answers. So patient group B, long-acting anticholinergic or long-acting beta agonist, and then it's short-acting beta agonist, which we already have the patient on. And so this is where monotherapy with long-acting bronchodilator, long-acting beta agonist is definitely appropriate and definitely recommended, so it's very different than with asthma. And then just to check, these other guidelines, he would fall under this category, FEV1 between 60 and 80%, treatment of long-acting bronchodilators is suggested, so that would meet both criteria. So B is the correct answer. So case 14, we have a 60-year-old man with COPD, smokes half a pack a day. He's had a gradual worsening of a shortness of breath over 1 to 2 years. FEV1 over FVC ratio, 55%. FEV1 of 63%. His CAT score is 10. No exacerbation or oral corticosteroid use in the past 2 years. He's currently taking tiotropium and albuterol. So which would be the most appropriate according to the GOLD guidelines? I'm seeing some blue. I'm seeing some answers of A. So this patient has the FEV1 criteria of stage 2, so, and then 1 or fewer exacerbations per year. CAT score of 10 or higher, so has more symptoms, low risk, so is patient group B. And we already have him on this. So you can use either long-acting cholinergic or long-acting beta agonist, and he's already on that preferred therapy, and he's already on the short-acting beta agonist. So then we would move to the alternative choice, which is to do a combination of a long-acting anticholinergic plus a long-acting beta agonist. So A would be the correct answer. So what about azithromycin for prevention of exacerbations? This is fairly recent. It just came out a couple years ago. And it was a pretty landmark study that looked at patients with COPD who are at risk of exacerbation. So these are higher risk people, not low risk. And they gave these patients azithromycin 250 milligrams once a day chronically for a year versus placebo on top of their regular COPD therapy. And the results showed a longer time to exacerbation, and it was actually quite impressive, 90 days. Was the actual difference, and that was significant. A decreased rate of exacerbations, which was significant, and the number needed to treat to prevent 1 exacerbation of COPD was only 2.86. So that's pretty impressive. That's like one of the lowest number needed to treat I've ever seen. And the quality of life improved more with azithromycin versus placebo, and that also was significant. So why don't we put everyone on azithromycin? Well, there is a downside. And that is the adverse effects that were seen. There were hearing decrements that were more common with azithromycin than placebo. And the number needed to harm was 20, which is a fairly low number needed to harm. And there's also increased incidence of colonization with macrolide-resistant organisms like you would expect. And it was 81% versus 41%. So that's quite an impressive difference, and that was significantly different. And because of these risks, the most recent 2013 GOLD guidelines still do not recommend routine treatment with chronic antibiotics, only when needed to treat exacerbations. But it's more of an individual assessment and judgment in patients who will need to be on the chronic azithromycin. And it is for sure being used. It's just not a routine therapy, and the evidence is quite good. So exacerbations of COPD. So when someone has a COPD exacerbation, short-acting albuterol is going to be the preferred therapy that everyone should get. So everyone should get short-acting albuterol to treat an acute exacerbation. And it's either via nebulizer every 1 to 4 hours, so that's quite frequent. And the number of puffs of albuterol is 4 to 8. So it's on the higher range, a little bit higher than with the asthma exacerbation. So you can use 8 puffs quite readily. And that's also every 1 to 4 hours. And generally short-acting ipratropium is also given to treat an acute exacerbation. In addition, systemic corticosteroids are effective and are generally recommended for most acute exacerbations. It used to be that the systemic steroids were only recommended in patients who had a baseline FEV1 of less than 50% or the more severe group C and D, but they've removed that, and now there's evidence showing that inhaled corticosteroids are going to be effective for most patients. And so now most patients should, with an acute exacerbation, should also get systemic corticosteroids. And the dose is 30 to 40 milligrams a day of prednisolone or the equivalent for 10 to 14 days. So you can see, too, that this dosing is different than with an asthma exacerbation. So it's going to be a longer-term therapy when we're treating COPD exacerbations than with asthma. Now, what about antibiotics? When should they be used for a COPD exacerbation? Well, there are 3 cardinal symptoms that indicate that there is infection present. And those three symptoms are increased dyspnea, increased sputum volume, and increased sputum purulence. So if someone has all three of those cardinal symptoms, then antibiotics are indicated to treat an acute exacerbation. Or if someone has two of the cardinal symptoms, but one of them is increased sputum purulence, then antibiotics are indicated. Or if it's a severe COPD exacerbation requiring mechanical ventilation, then antibiotics are indicated. If none of these apply, then antibiotics are not indicated to treat an acute COPD exacerbation. So the empiric antibiotics are used to cover the most common pathogens you see in a COPD exacerbation. That's strep pneumo, H. flu, and MCAT. And in more severe COPD patients, you might see some more Pseudomonas. It's more prevalent. Recommended antibiotic duration is 5 to 10 days. And the antibiotics that are recommended are broken down into uncomplicated COPD. If someone has complicated COPD with risk factors, and that includes comorbid diseases. What does that mean? Everyone's got another comorbid disease, so that's a little fuzzy. Severe COPD, more than 3 exacerbations per year, or antibiotic use in the past 3 months. And then if there is a risk of Pseudomonas infection, then the treatment is different. So those are the different choices. So we have a 56-year-old man with COPD. He's in patient group A. Presents to the clinic with several days of worsening shortness of breath, coughing, and production of cloudy, more copious sputum. Patients aren't ever going to say, I'm having purulent sputum. They're just going to say that it's cloudy and opaque, or you can't see through it, and it's not my usual clear stuff. And pulse ox in clinic was 95%. And in addition to nebulized albuterol and ipratropium every 1 to 4 hours, what else should be added? So is this someone who would need a steroid burst, and is this someone who would need an antibiotic? I'm seeing lots of Ds, which would be the antibiotic plus the steroid dose. So, bringing this slide up again, this patient has all 3 of the cardinal symptoms, so would need the antibiotic and would also need the oral prednisone, which is recommended for most exacerbations. Oof. Well, that was everything you wanted to know about COPD in 20 minutes. I could do like 5 hours on anticoagulation, so I'm not sure why in an hour and a half I have anticoagulation that's included, because this is a huge topic. So your chapter has a lot of information. What I did is kind of picked and chose certain key things that I wanted to bring out and talk about. And I'm focusing on warfarin. There are lots of new anticoagulants, but they are going to be covered more in the cardiology section, so I didn't want to repeat myself and use my time for other things. So we're going to be talking mostly about warfarin, and I'll mention the newer anticoagulants as well. And then again, just some of the key important points, but everything is included in your chapter. So starting out with anticoagulation for venous thromboembolism. Broken down into DVT, PE with reversible risk factors, or first unprovoked DVT, or proximal DVT or PE. And the goal INR is the same, 2 to 3, but the duration is different. So if someone has reversible risk factors and they have a DVT or PE, only 3 months of therapy is necessary. If it's unprovoked, then it's at least 3 months, and then extended VKAs, vitamin K antagonists, which is warfarin, if low, moderate bleeding risk, or just 3 months if high bleeding risk. So in the new 2012 CHEST guidelines, they've added the bleeding risk, which I think is still in its infancy as far as assessing bleeding risk, because there's lots of different models out there, and even in the CHEST guidelines, it's a little fuzzy, and there's conflicting bleeding risk models out there, but it's really just focusing on, like, making us think about the bleeding risk. So if someone, even if they've had an unprovoked idiopathic DVT or PE, that if they have a high bleeding risk, we're just going to treat that event, and then we're going to take them off the warfarin, and we're not going to continue it long term. But if they have a lower moderate bleeding risk, we are going to continue it long term, and by long term, I mean lifetime is basically what it's saying. Now, the other interesting thing here is this box right here. If it is a recurrence of an unprovoked VTE, so someone has an unprovoked PE, and then a year later, after they've finished their treatment, they have another unprovoked PE, that extended therapy is only recommended for low to moderate bleeding risk, that you would only treat with 3 months total and then stop the warfarin if someone has a high bleeding risk. So that's kind of new and that's kind of different, right? It used to be if you had 2 PEs, 2 DVTs, you're on warfarin for life. Well, now the recommendation is if they have a high bleeding risk, you may not be. And so I just underlined some of the things I wanted to point out. So in the CHEST guidelines, when they say to assess the bleeding risk, it's a little fuzzy when you look at their long list. As risk factors for bleeding, they include age greater than 65, and they include age greater than 75. Well, that doesn't make any sense. So I take that as if they're age greater than 65, it's a risk factor, and you wouldn't count it twice if they were over 75. So they list everything here, and then when you count up the risk factors, the low risk is 0 risk factors, moderate risk would be 1 risk factor, and high risk would be 2 or more risk factors. And that's when we're applying it to this VTE case where we're determining if they need long-term extended therapy or do we stop at 3 months. Now there's other models out there, and a very, very common one, and this is not in your chapter or in your slides. I added this after I turned those in. Another tool that is often used is the has-bled score. And when you look at these criteria, they're very similar. They pretty much mirror, except for a few small differences, what the CHEST guidelines outline for their risks. But it makes it more simple and easier to remember, because we all like things that are easy to remember, right? So we has bled, so each of the first letters of here, they spell out has bled. And some of them have 2 things like abnormal renal and liver function, which are also included on the previous slide. But here it's 1 to 2 points. So if they have both of these, it's 2 points, 1 point each. And then bleeding history or predisposition, that's kind of a broad bucket thing. So what's disposition? So if they have the propensity to bleed, or you think that they might have a higher risk of bleeding, that's kind of a subjective. So that would be a point as well. Labial INR, so if someone's on warfarin and they're really hard to control, that would also be a point. Elderly, they have just the 65. And then they have drugs, and this could be 2 points because it's concomitant antiplatelet or NSAID use or alcohol abuse, so you would count each of those. And the difference here is that with the has-bled score, their criteria is a little bit different. They have low risk is 0 risk factors, moderate risk is 1 risk factor, 1 or 2 risk factors, and high risk is 3 or more risk factors. Okay, switching gears to valve replacement, I wanted to point out here that when I updated this from the previous guidelines to 2012 guidelines, there are some things that are included in your slides and chapter that should be taken out. So where there's a lines through here, just cross those out of your handout. And what I want to point out here is that with the bioprosthetic heart valve replacement for mitral, it's warfarin for 3 months and then aspirin. For aortic valve, in normal sinus rhythm, it's only aspirin. For an aortic mechanical valve replacement, the goal is 2 to 3. But for mitral, it's 2.5 to 3.5. And for any type of mechanical valve replacement, it's recommended that if the patient is at low risk of bleeding, that aspirin should be added. Some other points on adjusting warfarin dose. If someone's INR is out of range, the warfarin should be increased or decreased by the cumulative weekly dose, and generally between 5 and 20% is what the adjustment's going to be. If the INR is high, you might hold a dose or two and resume at a lower dose. And you do not generally need to adjust the INR or adjust the warfarin if the INR is within 0.1 of the goal, but you might want to monitor more closely. So if someone's goal is 2 to 3 and their INR is 1.9, or if it's 3.1, and maybe they were on monthly INRs before, well, now you continue the same dose, but just check it sooner. And the 2012 CHEST guidelines also state that if the INR is stable therapeutic and there's a single out-of-range INR that is within 0.5 of the goal INR, either above or below, that the current dose should be continued and recheck the INR within 1 to 2 weeks. And I believe that this needs some clinical judgment applied to it because they don't really define what does that mean, stable. Stable for how long? And obviously if someone is 1 month out from a massive PE and they've been stable for a month and then they have one reading of 1.5, I'm probably not going to keep it at 1.5 and follow these instructions. So you need to use your clinical judgment. Or if it's a 99-year-old who falls a lot, who has AFib, and her INR comes back at 3.5, I might not continue it. So I might lower the dose. So obviously you're going to apply your clinical judgment. And remember that it takes 5 to 7 days after dose change for the full effect to be reached. So for the warfarin reversal guidelines, this changed in the 2012 CHEST guidelines, and they break it down to between 4.5 and 10 with no evidence of bleeding, and then greater than 10 with no evidence of bleeding, and then the last category is major bleeding. So when we're between 4.5 and 10 with no evidence of bleeding, the big change in these recommendations are that they recommend against routine vitamin K. And the instructions at this level is to omit 1 to 2 doses of warfarin and then monitor the INR more often and then restart the warfarin at a lower dose once the INR falls into the therapeutic range or is getting close to the therapeutic range. If the INR is greater than 10 with no bleeding, then vitamin K, right here, is 5 to 10 milligrams is recommended. So only when the INR gets above 10 is oral vitamin K recommended. Again, with applying clinical judgment to specific patients, because we often will go against this based on specific patients. And then if there's major bleeding, hold warfarin, give IV vitamin K and prothrombin complex concentrate, and then if needed, repeat the vitamin K. Okay, so we have a 30-year-old woman receiving warfarin for proximal DVT. She was taking oral contraceptives at the time her DVT was diagnosed, and those have since been discontinued. What is the most appropriate duration of warfarin? Okay. That was easy. She's got reversible risk factor, so treatment is 3 months. Okay, we have a 63-year-old woman with a history of mechanical valve replacement, hypertension, dyslipidemia. Her meds are warfarin 8 milligrams, aspirin 81, lisinopril, and atorvastatin. What is her goal INR? Easy, right? 2.5 to 3.5. And just remember that she's on the aspirin, and so that is recommended that she also be on the baby aspirin along with her warfarin. Now, what if she had an aortic mechanical valve replacement? And her goal is 2 to 3. Easy, right? And addition of aspirin if she's low risk of bleeding. Okay. A couple other updates with the 2012 CHEST guidelines. They recommend against bridging with either low molecular heparin or unfractionated heparin for a single subtherapeutic out-of-range INR in a normally stable patient. Again, the evidence is C. Clinical judgment is used, but this is what the guidelines state. And again, we often may bridge in those patients that are high risk, again, month out from a PE with a INR of 1.2, well, we might actually do it. So again, it's evidence of C, and so there's clinical judgment that needs to be applied to this, but that's the general recommendation. The other new recommendation in the 2012 CHEST guidelines is it was always only 4 weeks in between INRs. That was always what was recommended. And now in the 2012 CHEST guidelines, they suggest INR testing frequency up to 12 weeks in patients who are consistently stable or therapeutic. And there's some controversy about this, but we do apply this in several patients, quite a few patients actually. And when I interpret consistently stable or therapeutic, for me, that's like a year and a half with their INR always being in range and their dose not being checked. That's just my, I mean, don't write that down. That's just not going to be tested on them in the exam, but that's just my interpretation. Like if they have one that's out of range in that year and a half, or even 2 years sometimes, I'm not going to go every 12 weeks. But we have several people who they're always in range every time, and years have gone by, and they're coming in every month, and they're always in range, they've been on the same dose for years. Why not go every 12 weeks? And then just the education is very important, that if you notice any bleeding, any bruising, anything unusual, you come in sooner. So we really stress that. But this is controversial, but this is a recommendation from the guidelines. So we have a 79-year-old man who's taking warfarin 5 milligrams a day for AFib. He has a history of depression and GERD, and he started on fluoxetine 1 month ago and omeprazole 6 months ago. He has 5 and 2 and 1 milligram tablets, and that'll be important. Denies signs and symptoms of bleeding. His last INR, which was 6 weeks ago, was in range. And his INR today is 8. So first of all, why did his INR go up? Drug interaction, likely, right, with fluoxetine. So we have to, when we're doing our assessment, come up with a plan. Okay, is this a chronic interaction, or is this an acute thing that's not going to, is it going to go away, or is it not going to go away? Well, fluoxetine is probably going to be continued, so this is a chronic interaction that we need to take action on. So which is the best action to deal with this INR? Okay, I'm seeing a lot of C. So, bringing up this chart again, this patient falls into this criteria of the INR between 4.5 and 10. Recommend against vitamin K, omit 1 to 2 doses of warfarin, and then monitor the INR. Don't just hold 2 and then restart the warfarin at a lower dose. And then reinitiate at a lower dose when the INR falls into the therapeutic range. So, he was taking 5 milligrams a day, and he has 5 2s and 1s, and that's really important because when you adjust the dose, you have to do it based on what strengths they have, and remember also, simple is always better. So what would be the best dose to change him to? He was on 5 milligrams a day. I'm seeing lots of C's. That would be a 20% decrease, so that would be within the range of 5 to 20% of the weekly dose, and the INR is quite high, so it's good to go with more than 20% change. It's easy. He has 2 milligram tablets. He can take 2 of them. It's the same dose every day. Once you start alternating days with someone who hasn't done it before, that can sometimes be tricky. It's done a lot, but if someone's not used to it, that can be a problem. You want to make sure they have a pill box. So there's a lot of complicating factors, so this would be the easiest thing for this patient to do. Okay, interruption of warfarin for procedures. This, I just want to start out that although there's guidelines on this, in the CHEST guidelines, they really clearly lay out what you're supposed to do when someone is undergoing a procedure, whether you should bridge or not. There was a recent meta-analysis that looked at all the evidence out there, and there really isn't good evidence on this. And so now there's controversy about this because what all the evidence seems to show that if you bridge with therapeutic dose low molecular weight heparin, the risk of bleeding is like serious bleeding was 3-fold higher, and any bleeding was 5-fold higher than not bridging without a difference in thromboembolic events. Again, this is a meta-analysis. It's looking at studies that the studies all have different problems with them, so it's not perfect, but there's not good evidence about bridging. And so now there's concern about bleeding risk and what is their actual thromboembolic risk for the short time that they're holding their warfarin for a procedure versus that bleeding risk. So I just wanted to throw that out there, that there is some controversy about this, and we can't take lightly the bleeding risk of bridging patients with therapeutic dose low molecular weight heparin. Okay, so that said, we have a patient who's undergoing a procedure, and the first step is determine the bleeding risk during the procedure. And this is often going to be up to the surgeon. Like, we know if someone's getting X, Y, or Z surgery, I don't have enough knowledge to say, oh yeah, that's a really high bleeding risk. I mean, sometimes you can, but sometimes there's surgeries that have a lot higher bleeding risk than others, and so that's a very important consideration to take. And next, determine the thromboembolic risk of the patient's underlying condition. And for minor dermatologic procedures or cataract removal, the CHEST guidelines recommend continuing the warfarin and using local measures. And they used to always say in the CHEST guidelines that for minor dental procedures, do not stop warfarin, continue warfarin, and use local measures. And in the 2012 CHEST guidelines, they changed that a little bit. And it was always our thing to, tell the oral surgeons, guidelines say you don't have to stop the warfarin and keep going, and they never liked that. So now in the 2012 guidelines, they give you the option. You can either continue the warfarin or continue the warfarin and use an oral prohemostatic agent, or stop the warfarin, and they say 2 to 3 days before the procedure, which is less time than you would for other surgeries. So now there is that option to stop it. It's written in there, so yeah. But you can see the evidence is C, because there's just not good evidence. So when we're assessing the patient's thromboembolic risk, for a high risk of thromboembolism, this would be a more than 10% annual risk, not a more than 10% for the week that you don't have any warfarin in you, or a therapeutic dose warfarin. And for each of these three categories, mechanical heart valves, AFib, and VTE, there's specific criteria, and that's included in your chapter for high risk, moderate risk, and low risk. And the recommendation for this high risk, if they meet any of these criteria, that these patients should be bridged with therapeutic dose low molecular weight heparin. For moderate risk thromboembolism, which is outlined in your chapter, it's very obvious that there's little evidence, because the recommendation is to bridge, the decision to bridge or not to bridge is based on individual risk factors. So, I'm not sure what that really is supposed to mean. How are you supposed to apply this to a patient? I can tell you that with this recent data, with the risk of bleeding, I may lean towards not bridging, because that's the option. And I've personally also seen, whenever you see something in your own practice, I've seen patients who bridged who've had major bleeding complications, had to go back and redo surgeries. It can be a big deal. And then for low risk of thromboembolism, the recommendation is do not bridge. Just hold the warfarin prior to the procedure. So the specific instructions for bridging with low molecular weight heparin: when it's done, the warfarin should be stopped approximately 5 days before surgery. And then there can be 1 day with nothing, because the INR is not going to fall that low with one held dose of warfarin. But on day 2 of the warfarin being held, start the therapeutic dose low molecular weight heparin, and then do that every day. And there's either twice daily or once daily dosing for therapeutic dose low molecular weight heparin. If once daily dose is being used, the last dose should be the morning before the procedure, and consider doing a half a dose. If twice daily dosing is used, then the last dose should also be the morning of the day prior to surgery, but the full dose. And check the INR the day before surgery if feasible, and if the INR is 1.5 or higher, then vitamin K should be given. And post-op, the low molecular weight heparin should be commenced between 24 and 72 hours after surgery. And this is based on the bleeding risk, and we usually leave this up to the surgeon. And whatever the bleeding risk is and however the patient did, that's when it's going to be started. And then the warfarin can be started 12 to 24 hours after surgery because that's not going to have an effect right away. So even if there is still a high bleeding risk, the warfarin can still be started. And then the low molecular heparin is continued until the warfarin is therapeutic. And I have here the dosing for therapeutic dose, subcutaneous low molecular heparin. And again, you can see that some of them have both once daily and twice daily options. And in the previous guidelines, low dose low molecular heparin was a very viable option to use for bridging. And in the 2012 guidelines, they've kind of taken that out of the picture. It's not clear, though, because it depends where you look. They really say we are focusing on the therapeutic dose low molecular heparin for bridging, because that's what the studies have looked at, and that's where the evidence is, even though the evidence is not that great. And when we're talking about low dose or the prophylactic dose, that would be if you're choosing not to bridge, but you're worried about preventing thromboembolic events after surgery, so if they're immobilized, and like you would even if someone wasn't on warfarin. They're talking about prophylactic dose to prevent VTE after surgery. So if someone has AFib, we still might be worried about their VTE after surgery because they're going to be immobilized. So then the low dose can be used to prevent venous thromboembolic events and not arterial. So we have a 77-year-old man with AFib, hypertension, diabetes. He has a history of a TIA 3 years ago. He's having major abdominal surgery in 1 week and will need to hold his warfarin. Which of the following is most appropriate bridge therapy for him? Let's walk through this one together. So for AFib, when we assess severity, we look at the CHADS-2 score. And this patient has a CHADS-2 score of 5, which would put him in the high risk of thromboembolism category. So the recommendation is to bridge with therapeutic dose low molecular heparin, which would be C, enoxaparin 1 milligram per kilogram BID. Okay, now I'm going to just touch on some of the newer anticoagulants. And again, you're going to get more details of this in cardiology. But dabigatran is an oral direct thrombin inhibitor, and I put the BID in there because this is important. It's dosed BID, and it's only indicated in atrial fibrillation. And when it first came out, I think they started with a 30-day expiration, and they increased it to 60-day, and then now it actually is a 4-month expiration once you open the bottle, because the capsules are very sensitive to moisture. And the other key point here is there's no known agent to reverse bleeding. And from my ambulatory care standpoint, BID dosing is difficult enough, and you can't take the capsules out of the bottle. They have to be kept in the original container because there's a desiccant in the cap. So you can't take them out and put them in a pill box. So it may affect adherence in people who are also, people with AFib are generally older and they have other conditions. They're on a lot of meds and they use pill boxes. So that could be a big issue for adherence. Rivaroxaban is an oral direct factor 10A inhibitor, and this is dosed once daily. It's the only one of the new ones that is once daily dosing. And it's indicated in prophylaxis of VTE after total hip or total knee replacement surgery, also indicated for AFib, and indicated for the treatment of DVT or PE, for the reduction of risk of recurrent DVT and PE, and then long-term treatment. So if someone has multiple DVT PEs and we are giving, or they have one idiopathic and we're giving them long-term treatment, this is indicated for long-term therapy. And just like with dabigatran, there's no antidote. And I think that's the thing that makes a lot of people nervous, is that you can't reverse it. And although the half-lives of these agents are short and they do reverse on their own fairly quickly, if there's a life-threatening bleeding emergency, it's just not quickly enough. And then there's apixaban. This is the newest one. This is also an oral direct factor 10A inhibitor, and this is dosed BID, only indicated for AFib at this time, and again, no antidote. So that was a really quick rundown of these new ones because they're covered in much greater detail in cardiology. And there was another one that's, I honestly have not ever seen this used. but this is a sub-Q injection, dose BID. It's called Deserudin or Ipravasc, and it is a specific inhibitor of human thrombin, and it's made from that hirudin from medicinal leeches. It's structurally similar to that, and it is indicated for DVT prophylaxis after total hip replacement surgery. Whew. We really flew through that anticoagulation stuff, didn't we? So now we have 15 minutes left for adult immunizations. Every year in January-ish, sometimes February, by the time they come out, the CDC, or the ACIP, which is part of the CDC, releases their new immunization guidelines. So they do come out yearly, and there usually are some pretty significant changes each year when the guidelines come out. And in your chapter, you have a copy of this, which is a lot more easy to read than this very busy slide I'm showing you up here. And a really important piece is that also in your chapter, you have the footnotes that go along with this. And you really can't look at this chart on its own and make decisions based on on specific patients. You really have to look at the footnotes, because the footnotes outline specific criteria, specific age groups, specific indications. So it's very important to look at the footnotes. And they're very, very extensive, so I'm not going to go over all the different footnotes, but they are there in your chapter. What I wanted to highlight is some of the major changes in the 2013, the new guidelines from last year. There was major changes last year from the year before, and we can't go back and look at all the major changes in the last 10 years, so I'm just picking the major changes since last year. For the first time, the pneumococcal PCV13 Prevnar is included in the adult immunization schedule. Because Prevnar has always, or not always, but is usually in the pediatric immunization schedule, and is now for the first time in the adults. And it's recommended for adults age 19 and older who have immunocompromising conditions or certain other conditions, and those are included in your footnotes, if they've not previously received Prevnar or PPSV23, which is Pneumovax, the other pneumococcal vaccine. And it's recommended to have one dose of the PCV13 followed by one dose of the PPSV23 or Pneumovax 8 or more weeks later. And if a patient has already received the Pneumovax, then the Prevnar should be given 1 year or more after. So it's kind of complicated, but it's only for specific patients, so this is not going to be that common of a thing that you're going to see. There's some new information, but mostly clarification with PPSV23 or Pneumovax. And that is, there's always been a lot of confusion about the revaccination and how many should you give, and this has always been a complicated issue, and so there's some clarification on this. A one-time revaccination with pneumococcal vaccine is indicated 5 years after the first vaccine in those conditions I have listed here. Again, not super common except for the immunocompromising conditions. We see that more often. And for persons 65 years of age or older, a one-time revaccination is recommended if they were vaccinated 5 or more years ago and were less than 65 at the time of the first vaccination. So generally, pneumococcal vaccine or Pneumovax is indicated after age 65. But if someone has a condition or a reason to receive it early, then they should get it again after age 65 is the bottom line, if it's been 5 or more years. Now there's clarification that if revaccination is indicated 5 years after the previous dose, and they got both their doses before age 65, so they have an immunocompromising condition, for example, and then they reach age 65, then they should still receive another revaccination if at least 5 years has passed. So that would mean that they could get 3 doses. That was always the confusion. Should someone get 3 doses or not? And if the Pneumovax is indicated, it should be given to patients who are uncertain of vaccination status or don't have records of previous vaccination. They added that too because that was always a question. well, did you get the pneumonia shot ever? Yeah, I think I did. I think so. But people get the pneumonia shot confused with the flu shot, and they just don't really know. And if we don't have records on it, it was always an issue of like, oh, should we still give it? But now it's clear that if it's unknown, you should just still give it. So there are some changes with the Tdap recommendations as well. Prior to 2013, the age group over 65, it was not recommended for universal vaccination unless certain criteria were present. If someone was a caregiver to an infant less than 1 year of age, then they should get it, and there were certain criteria. But now they've changed it that routine vaccination of all adults is now recommended, including those age 65 and older. And the other new thing, which is very different, is now it's recommended that a single dose or one dose of Tdap should be given to all pregnant women at every pregnancy. And it's preferred during 27 to 36 weeks gestation, if possible. But if someone gets pregnant 6 times, they should get their Tdap 6 times with each pregnancy. And the thought is that it's going to help confer some protection to the infant. And the other tip, and I think this isn't really that new, but it's more of a reiteration, for all persons, Tdap can be given regardless of the number of years since the previous Tdap or the previous tetanus booster. There's some changes coming with the influenza vaccine, and it's just the 2013 guidelines are just kind of preparing for the changes that will occur with next flu season, which is still a ways away here. But the live attenuated vaccine, the FluMist, will be changing from a trivalent to a quadrivalent vaccine. And the inactivated influenza vaccine, which is the shot, may also change to a quadrivalent. They don't know yet. They're thinking about it. So to prepare for that, thinking about it and the possibility that might change, they're changing the abbreviations and the terms, because the inactivated vaccine was always called that trivalent inactivated influenza vaccine with the acronym was TIV. They're just changing it to IIV, inactivated influenza vaccine, in case they decide to change to the quadrivalent. So that way both the FluMist and the shot are both going to be the quadrivalents. They just wanted to change the terms now. And they've also clarified that individuals with egg allergy with hives only may receive the IIV but not the LAIV. For HPV, info on pregnancy was added. It's not recommended in pregnant women, but pregnancy testing is not needed prior to vaccination. And if the first HPV vaccine is given inadvertently during pregnancy, and I'm really glad they added this because we actually have had this happen a couple times in my clinic, no intervention is needed, but the remainder of the 3-dose series should be delayed until after pregnancy. Okay, so we have a 71-year-old woman with COPD. Her only med is tiotropium. She received the influenza vaccine last October, and her last tetanus booster was at age 65, and her Pneumovax was at age 60. She has not previously received the zoster vaccine, but had a severe zoster infection 5 years ago. So which one of the following vaccines she'll receive at her next October clinic appointment? Okay, so I'm seeing some D. So first I just wanted to point out, why did she get the pneumococcal vaccine before age 60 in the first place? Well, these are the criteria of patients who should receive it prior to age 65. And so she falls under the COPD category. And then we have that revaccination, and so since she's more than 65 now, and it's been more than 5 years since her last pneumococcal vaccine, that would be indicated. And Zostavax, this question comes up a lot, that what if someone has had a previous zoster infection? And Zostavax is indicated in all adults age 60 and older, and everyone who gets it should receive it whether or not they've had a prior episode of zoster or not. And then with the Tdap, all adults age 65 and older included should receive Tdap. It doesn't matter how long ago. So She would need the influenza, she would need the Tdap, and she would need the zoster, and she would need the pneumococcal vaccine. So D is correct. And one last case. We have a 20-year-old woman who is going away to college, living in the dorm. She smokes half a pack a day, no other medical conditions. She's up to date with all her routine childhood vaccines, but no vaccines in the last 11 years. She's not sexually active, and she has not yet been sexually active. So what vaccines should she receive today? Okay, I'm seeing some B's and a D and mostly B's. So meningococcal vaccine. This is indicated in the circumstances that you see listed on this slide. And this is the one that applies to this patient. First-year college students up through age 21 who are living in residence halls should be vaccinated if they have not yet received a dose since age 16. For pneumococcal vaccine, smokers age 19 to 64 should receive pneumococcal vaccine. So that would be her indication for pneumococcal vaccine. And for HPV, is recommended between ages 13 and 26 if not previously vaccinated. So at first it's recommended between age 11 and 12, but she was not previously vaccinated, so it would be indicated. And, to back up here, it's ideally prior to sexual activity, so that's good because she has not been sexually active yet. But even if someone is sexually active and has not received it, they should still get it. And the other question that comes up, it still should be administered to women with a history of HPV or genital warts, abnormal pap, and any of that. So they should still receive the HPV vaccine. And then Tdap, all adults. So she would need all four.